My name is Melissa Bosworth, and I'm an affiliate faculty at Regis University under the Health Services Administration program. I'm also a graduate of the HSA program, and I have worked for the past nearly 5 years in rural health care. Previous to that, I have experience with administration with developmental disabilities and then oral health care at a national level.
How do you define rural America?
There are several specific definitions of rural, and it depends upon who you ask. But the one that's most widely accepted is a community that has less than 20,000 people. If you think about the population of the entire United States, about 20% of American citizens live in a rural community. In Colorado specifically, I believe the number is 687,000 right now out of the 5 million, and as we know, Colorado is growing. So it's a small portion of citizens, but with a very unique needs.
What are the major challenges with workforce development, recruiting, retention, not only at the staff level, but at the medical provider level?
It is extremely difficult, and this is one of the challenges that rural communities face and sometimes will devastate a community. I said that 20% of the population lives in a rural community, but only 8% of graduating physicians choose to practice in a rural community. So there's a very large disparity. And when you think about physicians specifically, they produce an economic impact of $889,000 a year per community. And that may not sound like much, but for one that's very small, that's significant in their overall budget. And then it also creates 23 additional jobs for the community. A lot of the struggles that communities face around workforce in the healthcare region are pay. A lot of times they're not able to pay as much as an urban area. Professional isolation. Many physicians and also nurse practitioners, PAs, they all struggle with that. Spousal satisfaction is one of the top ones, and actually smart hospital administrators, when they're interviewing a clinician to come in, will, if the clinician is single, will also introduce them to their most eligible bachelors or bachelorettes. It may sound completely crazy, but it's actual truth that's what happens. As far as entry level, that housekeeping, dietary is always turning over and over. Long-term care is a huge, huge problem as well. So the only growing population in rural Colorado are people over the age of 65. Yet the long-term care availability for those people is scarce, and oftentimes they're having to relocate out of their communities, away from their families. And we know that that has a devastating effect and actually will oftentimes reduce life expectancy.
So other than the incentive that you mentioned about meeting other people in the community, what other motivations are there that can be provided that are non-financial?
That are non-financial. When I talk with rural clinicians, they get, and actually administrators too, they get very excited because they get to do the whole scope. While they're in an urban area, they usually have to be very specialized in a certain area, whether they're a specialized physician or not. But even in a family practice, they may not be able to do the full scope. But a rural doctor, they'll be able to birth babies, they'll be able to treat the colds, they'll be able to do prenatal care, they'll be able to do the cardiology care, diabetes care, they'll be able to do the full scope of practice. Also, people say that they feel more part of that community as well. In an urban area, we don't know our neighbors as much, and a true rural clinician or administrator wants that type of connection with their community. Retention rates, however, aren't always the best. So I did my thesis on this to see what the retention rate of rural physicians were in Colorado. And between 2007 and 2012, which was a 5-year gap, only 38.5% of physicians stayed in the same community. So administrators are constantly having to recruit.
Are there staff level positions that are homegrown typically, or even at staff level, do you need to recruit from outside the rural area?
You do. Usually they are homegrown. That can be good and bad because providing education to some homegrown folks can be difficult. They have to leave the community to go get that education. Or they may do an online program, but it takes them out of that. What I see most often now is that those staff positions around revenue management or HR practices, those types of things are being outsourced to larger corporations that will come in and do that. That can help with operations, but it also then takes that economic impact away from the community and puts it back in an urban center. So some argue that it actually hurts the community even more.
So you mentioned that it's sometimes not possible to provide compensation that matches urban centers. What other financial considerations or challenges are there in the rural area?
Housing is very difficult, and communities have gotten creative in bringing in their economic development councils, their local businesses to try to help with the housing situations. But that's something that's always discussed is these small communities don't have adequate housing. Also schools. Schools are very important if you're bringing somebody in and recruiting because many have families and they want to make sure that their children have schools that they really like. Although most of the communities that I'm in, the practitioners really do like the schools and they like the small setting. They like that their kids can walk to school and not be fearful. On the financial side, and there are state loan repayment programs and then also national loan repayment programs. That's often a recruitment tactic, although it's extremely competitive, and a minority of clinicians are actually awarded for those programs.
Some rural communities, or maybe many rural communities, need to address social issues beyond the social determinant of medical care, which we think makes up maybe 20% of all the social determinants of health. How do rural communities address the other 80%? Education, healthy food, healthy living, exercise, drugs, all that stuff.
If you were to ask my opinion, which you are, I would say that the social determinants of health, other than their medical care access, is the biggest problem in rural communities. You look at obesity rates, you look at their food deserts. Most of these rural communities are very isolated in food deserts. Although they're on the plains, they're growing food all around. That doesn't get into their grocery stores or it's not affordable. Poverty rates are significantly higher in rural communities, and there's a direct correlation between education level and poverty. Interestingly enough, though, if you actually look at the data, it's not with high school graduation. So poverty-stricken families in rural areas, their children are still graduating high school, but they're stopping at that. They're not getting bachelor's degrees. Or they are getting bachelor's degrees, but then not coming back to the community. So the healthy living also. There's an interesting story about a community in Southeast Colorado where a Denver foundation decided to give money to the community, and they built bike paths all over this community. And they thought that would improve their obesity rates and promote healthy living. Unfortunately, a year later, they saw nobody's using these bike paths at all. And they started asking the stakeholders, the citizens that actually lived there, and find that it was very stigmatizing to ride a bike. It meant that you could not afford to drive a car. So you have to look at every community and its unique attributes because they are all not the same. The poorest county in Colorado is a rural county, and the richest county in Colorado is a rural county. So it's a very wide scope.
If you put on the hat of a futurist Where do you see rural health headed over the next 5 to 10 years?
I think there are two scenarios, and there are some great innovators right now in rural health across America that have some extraordinary ideas, but it's all going to be determinant upon policy, and policy at the federal level, but also policy at the state level. I believe that if rural health was given the option to afford flexible rules and regulations about how their health care is reimbursed and run, then they would succeed. They are already on the path of thinking beyond cure and into prevention. But then on the other side, the Affordable Care Act is primarily written to generalize and standardize all health care across urban and rural. And if that stays the way that it is, then a lot of rural communities are going to be very devastated. We're already seeing that out east. Colorado's very, very lucky that we have not yet had a hospital close, but there are two that I know of off the top of my head that are on the brink of closure. But if you look out east, there have been more hospitals close in the last 2 years than in all 10 years combined. So it's definitely at a tipping point.
Have we missed any major issues that you'd like to discuss?
I believe, just kind of on that note, regarding hospitals, they are usually the main economic driver of the community. In every rural community that I've worked with, they are one of the top 3 employers and one of the top 3 revenue generators. So it's very important to keep rural healthcare alive. And also, when you speak of rural hospitals, it's not just what we think of in urban settings. It's not you go to the hospital if you need to be an inpatient or if you need to go to the emergency room. The hospital usually also houses the clinic, and it houses the physical therapy or substance abuse or mental health. Everything is done within that system.